Your physician likely handed you that prescription bottle with the standard instruction, take one tablet each day. And like millions of Americans over the age of 60, you have been following that directive without fail, swallowing that pill with your morning coffee, assuming you are doing everything right. But here is the critical piece of information that Dr. Edward Sullivan almost certainly failed to communicate during your brief appointment. The specific time on the clock when you ingest your blood pressure medication, along with what you consume alongside it, can be the deciding factor between robust cardiac protection and leaving your heart perilously vulnerable. This is not a marginal difference. We are examining a disparity so substantial that researchers at the University of Vigo, tracking a cohort of 19,084 patients across a 6-year period, found results so compelling that the lead cardiologist on the project described this phenomenon as one of the most dangerously overlooked risk factors in the entire field of hypertension management. There exist 5 distinct timing errors that individuals taking antihypertensive medications commit on a routine basis. Some of these will catch you off guard with their subtlety, but the very first one, the error that is likely hiding in plain sight within your morning routine at this very moment, is the one that most people would never anticipate. Please remain with me. My name is Dr. Edward Sullivan. Over the course of 35 years, I have served as both an internist and a cardiovascular researcher. And I established this platform because the crucial dialogue that safeguards your heart should never be confined to a rushed 15-minute consultation in a clinical setting. The investigation I just referenced, formerly known as the Hygia chronotherapy trial, enrolled 19,084 adults diagnosed with hypertension and monitored their progress for a median duration of 6 years. The participants who were directed to take their medication at the hour of bedtime exhibited a staggering 45% lower risk of death from cardiovascular causes when compared to those who took their pills in the morning hours. That figure, 45%, was published in the prestigious European Heart Journal. That number alone should have fundamentally altered the way every single prescription for blood pressure medication is written by physicians worldwide. Regrettably, it has not, by and large. Before we proceed further into the material, I want to engage with you directly. Please drop your current age in the comment section below and respond to this question. Were you instructed to take your dose in the morning, or were you told to take it at bedtime? Furthermore, if you have ever doubled up on your medication after realizing you missed a previous dose, I am particularly eager to hear your experience. You are far from alone in this, and the information you share in the comments can provide invaluable insight to others who are watching. Here is the fundamental biological reality you must comprehend about your body and its relationship with blood pressure after the age of 60. Your cardiovascular system does not operate on a static level line. It functions according to a sophisticated internal clock known as the circadian rhythm. Blood pressure stands as one of the most tightly regulated variables governed by this internal timekeeper. In healthy individuals, blood pressure naturally declines by 10 to 20% during the hours of sleep, a phenomenon we refer to as nocturnal dipping. Subsequently, in the early morning period, typically falling between 4 o'clock and 10 o'clock a.m., there is a dramatic and abrupt surge upward as your body physiologically prepares itself to meet the demands of the coming day. This is medically termed the morning surge. Now, here is the critical danger. A study featured in the journal Hypertension established that this morning surge is directly responsible for 49% of all strokes and 40% of all heart attacks that transpire within any given 24-hour cycle. As we advance past the age of 60, our arterial walls undergo stiffening, losing as much as 30% of their natural elasticity, and this physiological change renders that morning surge more perilous, not less. Your medication must be biochemically active and at its peak potency precisely within that vulnerable window. Whether that is the case for you depends entirely upon the exact time you choose to take it. A great many people assume that coffee is merely a benign component of their morning ritual. Frankly, most physicians hold this same assumption. However, if you are prescribed a beta blocker, medications such as metoprolol, atenolol, or carvedilol, that morning cup of coffee may be actively working in direct opposition to your prescription medication. Let me explain the mechanism. Think of your sympathetic nervous system as the gas pedal in a car. Caffeine presses firmly down on that pedal. It elevates your heart rate, triggers the release of adrenaline, and temporarily spikes your blood pressure. Beta blockers function by blocking that exact same pedal, effectively slowing down your heart rate and diminishing the force of each cardiac contraction. When you consume your beta blocker and then drink your coffee within the same 30-minute window, you are simultaneously pressing the accelerator and the brake on your cardiovascular system. In the majority of patients, the medication ultimately wins that battle. However, in patients who have a documented history of arrhythmia or irregular heartbeat, the physiological competition between the stimulatory effects of caffeine and the suppressive action of the medication can actually trigger palpitations during the peak absorption window for caffeine, which is roughly 30 to 60 minutes after ingestion. A study originating from the Mayo Clinic's cardiovascular research program, which tracked 3,412 patients taking beta blockers over a 4-year period, discovered that those who consumed more than 2 cups of coffee within 60 minutes of taking their dose experienced a 22% higher incidence of symptomatic palpitations compared to those who strategically spaced their coffee consumption by at least 45 minutes. Consider the case of Margaret H., a 68-year-old retired schoolteacher from Baton Rouge, Louisiana. She had been taking metoprolol for 3 years. She presented to me complaining of a distressing fluttering sensation in her chest every morning around 9 a.m. She initially attributed this to anxiety. We carefully reviewed her daily routine. She drank her coffee at 7:30 and took her pill at 7:45. We made a simple adjustment, shifting her pill to 7 o'clock and her coffee to 7:50. The palpitations resolved entirely within a matter of 2 weeks. She later expressed to me, with understandable frustration, "Why did no one ever think to ask me what time I was having my coffee?" Pause here. The practical instruction is straightforward. If you are taking any form of beta blocker, you must wait a minimum of 45 minutes between taking your medication and drinking your first cup of coffee. Your medication should have time to clear your stomach first. Decaffeinated coffee does not carry any significant interaction and is safe to consume. For a synergistic tip, pair this habit with a full glass of water when you take your pill. Proper hydration facilitates consistent absorption of the medication and helps to reduce the concentration spikes that can drive these interactions. I have had patients look me directly in the eye and confidently state, "I know all about grapefruit and medication interactions. I have read about it." And then, when I inquire as to when they last consumed grapefruit juice, they casually reply that it was Tuesday while they are sitting in my office on Thursday. Pause and consider that. This is precisely the problem. Grapefruit and grapefruit juice contain specific chemical compounds called furanocoumarins. Think of your digestive system as having a security checkpoint, a specialized enzyme known as CYP3A4 that processes and regulates exactly how much of a drug enters your systemic circulation. Furanocoumarins effectively disable that checkpoint. They incapacitate CYP3A4 for up to an astonishing 72 hours following consumption. When that enzyme is blocked, calcium channel blockers, medications like felodipine, nifedipine, and amlodipine do not get metabolized and processed normally. Blood levels of the drug can rise to 2, 3, and sometimes even 5 times the intended therapeutic concentration. The clinical result is an exaggerated and dangerous drop in blood pressure, leading to dizziness, lightheadedness, and potentially life-threatening fainting episodes in older adults who already possess reduced vascular tone. Researchers at the University of Toronto's Clinical Pharmacology Unit tracked this specific interaction across 2,891 patients over a 3-year period. Their findings revealed that patients who consumed grapefruit products within 72 hours of dosing had a 31% higher rate of hypotensive episodes, which are dangerously low blood pressure events, when compared to those who completely avoided grapefruit in their diet. Consider the case of Robert D., a 72-year-old retired electrician from Phoenix, Arizona. He had been taking amlodipine for 2 years with no reported issues. His wife then began purchasing a new brand of juice, a citrus blend that unfortunately included grapefruit. He did not read the ingredient label. 3 mornings later, he rose from the breakfast table and simply collapsed to the floor. There was no cardiac event, no heart attack, no stroke. His blood pressure had plummeted to a critical 86/52. When I meticulously pieced together the details, the culprit was unmistakably clear. If you are taking any calcium channel blocker, you must specifically ask your pharmacist this question. Is grapefruit a known interaction concern with my exact medication? Do not make the assumption that the answer is no. For all calcium channel blockers, you should completely avoid all grapefruit products and replace them with safer alternatives like orange juice, apple juice, or plain water. For a synergistic tip, magnesium-rich foods such as spinach and almonds, when taken alongside your calcium channel blocker, may help to stabilize vascular tone without interfering with the drug's action. You should also ask your doctor about checking your magnesium levels if you are on long-term calcium channel blocker therapy. This brings us directly to timing mistake number 3. And before I explain what it is, I want to share something with you. This particular error does not appear dangerous on the surface. It manifests as insomnia. It presents as a necessary trip to the bathroom at 2 o'clock in the morning. It looks like just another typical problem for an older person. Pause, but it is not. It is, in fact, one of the most preventable causes of catastrophic injury in adults over the age of 70. Diuretics, commonly referred to as water pills, represent one of the most frequently prescribed categories of medication for blood pressure treatment. Medications such as hydrochlorothiazide, furosemide, and chlorthalidone function by signaling your kidneys to excrete more fluid, thereby reducing overall blood volume and consequently lowering blood pressure. Think of it like draining a hose. Less water in the hose translates to less pressure against the walls. The critical timing problem is this. Many patients, often because they simply forgot their morning dose or because they were never given specific instructions, end up taking their diuretic in the late afternoon or evening. The drug then reaches its peak effect in the middle of the night. The kidneys excrete fluid, the bladder fills, the patient wakes at 1, 2, or 3 in the morning, and gets out of bed in the darkness with blood pressure that shifts dramatically when they stand up. This condition is medically known as orthostatic hypotension, and it affects nearly 30% of adults over the age of 70. What happens next should cause every cardiologist and geriatrician to pause with concern. The National Institute on Aging reports that nighttime falls in adults over 70 are the leading cause of hip fractures. And hip fractures, listen very carefully to this number, carry a one-year mortality rate of between 20 and 30% in patients over 70. That means 1 out of every 4 to 5 people who sustain a hip fracture after the age of 70 will not be alive 1 year later. That stark reality is the true consequence of taking your diuretic at 6 o'clock in the evening instead of 8 o'clock in the morning. A Brigham and Women's Hospital analysis, which is affiliated with Harvard, examined data from 14,872 patients receiving diuretic therapy. The researchers discovered that late afternoon dosers, those taking their water pill after 2 p.m., had a 44% higher rate of nighttime falls requiring emergency medical care when compared to morning dosers. Consider the case of Patricia W., a 74-year-old retired librarian from Columbus, Ohio. She had been waking up 3 times every single night for more than a year. She had been prescribed hydrochlorothiazide and was simply told, "Take once daily." No further guidance regarding timing was provided. She had been taking it with her dinner at 6:30 in the evening. After carefully reviewing her records, we moved her dose to 8 o'clock in the morning. Within just 1 week, she was sleeping soundly through the entire night. She called my office and said with palpable relief, "I feel like I have gotten my life back." Pause. The rule here is absolute. If you are taking a diuretic, you must take it before 10 o'clock in the morning. If you are taking a twice-daily diuretic, the second dose should be taken no later than 2 p.m. Write this rule down and place it on your medicine cabinet if you need to. For a synergistic tip, pair your morning diuretic with a banana or a small serving of plain yogurt. Diuretics can deplete your potassium levels over time, and natural potassium replacement can help to support a healthy heart rhythm. If this is the kind of clinically rigorous information you have been missing, real science, specific numerical data, and the kind of detailed explanation your doctor should have provided when prescribing your medication, then I urge you to subscribe to this channel right now. Every week I publish videos, precisely like this one, transforming peer-reviewed science into accessible language that actually helps you make better, more informed decisions about your health. The subscribe button is located right there on your screen. It costs you nothing, and it may very well save you everything. You have done it before. I know you have, because nearly every patient I have ever treated in my career has done it at least once. You forget your morning pill. You suddenly remember at 2 o'clock in the afternoon, during dinner, or just before you are getting into bed, and the instinctive reaction is, "I will simply take 2 pills tonight to make up for it." Pause. For some specific medications, this is relatively low risk. For others, however, it can actually trigger a full-blown cardiovascular emergency. Here is what happens inside your body when you double the dose of a calcium channel blocker or a long-acting ARB, medications such as valsartan or losartan. Think of your arterial system as a network of flexible tubes under constant internal pressure. These medications function by relaxing the muscular walls of those tubes, thereby reducing resistance and lowering blood pressure. 1 dose performs this action gradually and safely. 2 doses taken at once can create a sudden, precipitous, and steep reduction in vascular resistance. Blood pressure drops sharply. In a younger adult with elastic, pliable arteries, the body often compensates effectively for this drop. However, in an adult over 65 with reduced vascular tone and possibly some degree of underlying coronary artery disease, that sudden drop in blood pressure can induce syncope or fainting, and in some cases, ischemia, which is insufficient blood flow to either the heart or the brain. The second version of this mistake is quieter but just as dangerous. Patients who are prescribed twice-daily medications begin taking them only once daily because it is easier to remember, and they do this without ever informing their physician. The blood pressure appears partially controlled. The doctor reviews the records and sees acceptable numbers, but the twice-daily protection that the medication was specifically designed to provide is operating at only half its intended capacity. Cardiovascular events that could have been prevented are not. Researchers at Johns Hopkins University tracked 8,211 patients with hypertension over a 5-year period. Those patients with documented dose-doubling events after missed doses had a 38% higher incidence of emergency hypertensive crises compared to those who maintained consistent single dosing. Furthermore, patients who inconsistently took their twice-daily medications had a 26% higher rate of cardiovascular hospitalization compared to patients who remained compliant with their prescribed twice-daily regimen. Consider the case of Dennis M., a 66-year-old contractor from Denver, Colorado. He had been taking amlodipine and valsartan for 4 years. He worked irregular hours, and his mornings were often unpredictable. Over time, he developed a habit of taking 2 pills in the evening whenever he remembered that he had missed his morning dose. He came to see me after his wife discovered him unconscious on the kitchen floor. His blood pressure had dropped to a dangerously low 79/48. There was no heart attack, no stroke, just an entirely preventable double-dose episode. Pause. The protocol here is clear, and it is non-negotiable. If you miss a dose and you remember later on that same day, you should take it as soon as you remember, unless your next scheduled dose is less than 4 hours away. If it is close to your next dose time, you should skip the missed dose completely and simply return to your normal schedule. Never, under any circumstances, double a dose without first calling your pharmacist, because the correct answer depends entirely on the specific medication you are taking. For a synergistic tip, set a daily phone alarm that is labeled with the name of your specific medication. Link it to a specific daily anchor, such as your first meal of the day or your routine of brushing your teeth. According to a 2019 UCLA medication adherence study, this behavioral pairing technique reduced missed doses by 63%. We have now arrived at mistake number 1. And I want you to listen to this explanation very carefully, because this is not a minor optimization or a simple lifestyle adjustment. This is a fundamental misalignment between how the vast majority of blood pressure prescriptions are currently written and what the actual scientific evidence definitively shows. Pause. For decades, for the entirety of my career, and for most of the careers of the physicians who are currently treating you, the default instruction on blood pressure medication has been to take once daily in the morning. This was a convention born in an era long before we understood circadian biology well enough to even question it. Today, we understand it very well, and the evidence is now unambiguous. Your blood pressure follows a biological rhythm that is as precise as a finely tuned clock. During sleep, it falls. In the early morning hours, typically between 4 o'clock and 10 o'clock a.m., it rises sharply as cortisol levels increase. The sympathetic nervous system activates, and your body prepares itself for the demands of the coming day. This morning surge is the single most dangerous cardiovascular window in any 24-hour period. It is the precise time when the majority of heart attacks and strokes actually occur. Now think carefully about what a morning dose actually does in your body. You take your medication at 7 o'clock or 8 o'clock in the morning. It absorbs over the next 1 to 2 hours. It reaches peak blood concentration around 9 o'clock or 10 o'clock a.m., just as the morning surge is already beginning to subside. By 4 o'clock or 5 o'clock the following morning, when the next surge is building once again, the medication has been declining in concentration for 18 to 20 hours. The window during which you need the most protection is precisely when your medication is at its weakest. A bedtime dose, however, changes this entire dynamic. You take your medication at 10 p.m. By 4 a.m., It is at or near peak concentration. It is fully active during the morning surge. The surge meets a pharmaceutical wall. Your arteries are protected at exactly the moment they are most vulnerable. This is not speculation or theory. The Hygia chronotherapy trial, which stands as the largest study ever conducted on the timing of blood pressure medication, enrolled 19,084 Spanish adults with confirmed hypertension. Half of the participants took their antihypertensive medication at bedtime. The other half took it in the morning. After a median follow-up period of 6.3 years, the bedtime group demonstrated a 45% reduction in cardiovascular death, heart attack, heart failure, and stroke when compared with the morning dose group, 45%. That is not a small or insignificant effect. That is the kind of dramatic number that should appear directly on the prescription label. Furthermore, a 2022 meta-analysis published in the Journal of the American Heart Association reviewed 11 randomized controlled trials involving 21,400 patients. The analysis found consistent evidence that evening dosing of ACE inhibitors and ARBs produced superior nocturnal blood pressure control, better suppression of the morning blood pressure surge, and meaningfully improved long-term cardiovascular outcomes. The authors of this analysis concluded that clinicians should consider individualized dosing schedules based on each patient's specific circadian blood pressure pattern. Consider the case of Eleanor F., a 79-year-old retired opera singer from Chicago, Illinois. She had been taking lisinopril for 11 years. She took it every morning at 8 a.m. Her blood pressure appeared controlled on paper, and her office readings were acceptable. However, when her cardiologist ordered a 24-hour ambulatory blood pressure monitor, the data revealed a very different story. Her blood pressure was surging to 162/94 between 5 o'clock and 7 o'clock every single morning. She was, as I often tell my patients, controlled at the wrong time of day. We switched her medication to bedtime dosing. 3 months later, her ambulatory monitoring showed complete suppression of the morning surge. Her cardiologist told her that her cardiovascular data looked better than it had in more than a decade. Eleanor told me, with a touch of regret, "I wish someone had told me this 11 years ago." There is an important caveat that I owe you for the sake of complete transparency. The Hygia chronotherapy trial has been questioned on methodological grounds by some researchers. Several subsequent studies, including the time trial conducted in the United Kingdom and involving 21,104 patients, did not find a statistically significant difference between morning and bedtime dosing in terms of cardiovascular outcomes. The science is not fully settled, and the debate continues. What is settled, however, is this: bedtime dosing has not been shown to be harmful in any study, and for many patients with non-dipping blood pressure patterns, it may offer substantial and meaningful benefit. The only way to definitively know whether you are one of those patients is to ask your physician for a 24-hour ambulatory blood pressure monitor. That diagnostic test tells the full story of your circadian blood pressure pattern, and it is the single most powerful tool available for personalizing the timing of your antihypertensive medication. If this video has given you something valuable, something that your last appointment failed to provide, please subscribe to this channel. Every single week, I publish videos exactly like this one. Peer-reviewed science, specific numerical data, real clinical context, and practical, actionable information for adults over 60 who deserve honest, evidence-based guidance about their health. I am Dr. Edward Sullivan. I have spent 35 years in medicine, and this is the conversation that should have happened in the exam room. Pause.